was on the back of the female mesh story, and we're very fortunate to have one of the world's most experienced male sling surgeons speaking next. Peter Rader came over to myself 10 years ago and taught me how to put slings in, and has been and is much in demand. So we're very fortunate to have you come today and tell us about your experiences. Peter Rader.
Right. Dear ladies and gentlemen, dear Chairman, dear Organising Committee, thank you for the invitation. It is indeed a privilege to be here, and I'm talking less about the advanced sling and more maybe on the dilemma of sling surgery at present. And when you are put in a position of doing sling surgery and then cases are made against doctors who implant slings and also device companies, you find yourself in a very awkward position, and doctors are quite poor in defending their good practice because we get very emotional about it, and we tend to focus less on what we do well. And I think the whole mesh issue has created a hell of a dilemma, and it's not so easy to get out of it. Conflicts of interest is I'm a co-inventor of the advanced male sling with Christian Gotzi, and I'm very happy to be an invited speaker at BAUS. Where is the problem? Just because we use a scalpel doesn't mean that the scalpel itself is a problem and should be banned from surgery. We are surgeons with good training, and we were used to be in control of what we do. And now, with regulatory forces and litigation coming onto the horizon, they destabilize a very solid profession, and that is very disturbing. Is the problem the products itself we use? Because all meshes we use today are polypropylene, and the accusation has been that some of these products are low quality. But we know that polypropylene in suture material is very good quality, and they maintain stability over long periods. Is the problem activist groups that feel that they should stand up for patients that have been damaged by surgery? Do we have a problem with our system in the courts, or is it a money-driven problem where a lot of money is invested and gotten out of processes against doctors and medical device companies? So there are a lot of issues. In 1997, AMID classified meshes into four types, the macroporous meshes being larger than 75 microns, the combination meshes type 2, macroporous and microporous, and then microporous less than 10 microns, where inflammatory cells cannot get into a clear bacteria that might have lodged into the mesh, and then submicronic pores or sheets of meshes, including biologics. Now, the meshes used today are all type 1, macroporous meshes, monofilament and lightweight. But even with the macroporous meshes, there are knots, and in between those knots, there are spaces that cannot be completely cleared of bacteria. So maybe knots is also a problem in meshes. There are patient factors that we have to consider when we implant meshes into patients, like smoking, obesity, diabetes, immunosuppression, previous wound infection, and also ongoing infection, like bad teeth or chronic skin sores. There are surgeon factors. Are the surgeons that implant meshes experienced enough and trained in prosthetics? Is the quick fix of mini slings in females, for instance, where we do day case procedures, sensible? Because patients come in from outside, get the procedure, go home the same day, and we don't know what happens on that day. But if you implant a mesh, even if it is a sling, it is a foreign body that you implant into somebody. And maybe this tendency to quick fixes or daytime surgery is not appropriate for sling surgery. We should have a clean technique, cause minimal tissue trauma, including diathermy, wounds, and we should have a reconstructive attitude, as most surgeons have today, as opposed to the smash and grab techniques of older cancer or trauma surgeons. Perioperative factors is, if you do a mole sling, you should have a sterile urine culture. And there should be absence of infections on all other locations of the body. Shaving should be done if you work in the groin just before surgery, preferably on the ward. The surgical prep should be done with alcohol. We need at least 1 IV dose of antibiotics intraoperatively, because in female slings it has been shown that even 10 colonies of bacteria being located onto a mesh that is implanted may lead to infection of that sling or mesh. And post-operative pain, especially in women, has been related to chronic low-key infection of meshes. We should stick to a good surgical technique, minimize the use of diathermy and tissue damage by forceps, and the surgical time should be as short as possible, but as long as necessary. The polypropylene meshes we use, they degrade over time. So you get the micro tears, and they lose the original form in various ways. The FDA produced regular clearance letters, and in 1953 they said that an implanted device must not be physically modified by tissue fluids, be chemically inert, not incite an inflammatory or foreign body cell response, be non-carcinogenic, not produce allergic reactions, stand up to mechanical stress, be fabricated in a form required at low cost, and be capable of sterilization. In 2010, the FDA said that degradation occurs in all currently used meshes. So the quality of the meshes that we implant degrade over time, of all meshes. In 2014, the FDA proposed that vaginal meshes be moved from moderate risk to high risk medical devices, class 2 to 3, and that requires a pre-market approval. All medical devices being produced in Europe nowadays need pre-market studies. That makes it very difficult for medical device companies to come up with new products, because it's timely and also it costs a lot of money. But all this regulatory may also be a little bit of a problem, because in countries like China, development of new products may be easier, and we might lose a lot of new development because our regulatory has been, on the one hand, sensible, but maybe on the other side also restrictive. There are a lot of procedures on the market for male incontinence, meaning that the ideal sling or device is not on the market yet. Just to comment on a few things on these devices. The reported gold standard is the AUS, the artificial urinary sphincter, and that causes a constant compression when the patient is not urinating. But when urinating, the cuff is emptied, the urethra opens up, and urination occurs through a non-obstructed urethra. There are many devices, balloons and cushions being placed onto the urethra, causing a constant compression and obstruction. And this compression remains during micturition, which I think is a problem and is nonsensical. Having the point of adjustability post-operatively introduces infection into the system because you have to breach the skin again. I don't think that's the final answer. I will come back to retroluminal slings. Biological materials have the problem that they lose tensile strength over time. And the old-fashioned fascial sling is a good alternative, but it is a bigger operation. BAUS19, as was mentioned, recommends that slings in the UK are only used, male slings should only be used as part of clinical trials, with the effect that, that they are virtually not implanted anymore at all. The retroluminal sling is a support sling distal to the membranous urethra by indenting the bulb distal to the membranous urethra and well underneath it. So it's underneath by a margin of 8 to 10 millimeters, so there's no direct pressure onto the urethral lumen, and by that, during moments of stress, there's a hammock support to the sphincter mechanism to lengthen this area of functional membranous urethra. So if regulatory forces and other forces dictate us what to do and what not to do in surgery, have we lost control of how we should operate? We have one problem in surgery. I can speak for Europe. There's a problem in quality control of surgical outcome. We don't have enough measures to control bad surgical outcomes of surgeons that have bad results. And there's not enough feedback to motivate these people to get better at surgery. I'm talking about surgery across the board. And also in the UK, it is very commendable. Implants are all entered into registries. In Europe, it's the case that implants are all registered, but by the financial department, where clinicians don't have insight. So it's very important that all implants, including slings and meshes, should go onto implant registries that are accessible for clinicians to monitor their own success and to be able to relate to other centers. Who trains us to operate? We should not leave medical device companies the main force behind introducing new operative techniques into surgery. I see a lack of leadership at university clinics. This is a dilemma that should be addressed. And where do we learn to operate? In centers of excellence or just through fellowships in private clinics assisting private surgeons? I think this is a little bit of a dilemma. And why do we still operate and implant meshes and slings if we are being litigated? Well, we still have patients with big problems. And a male sling, in this instance, is at the moment the best alternative we have, even with all the problems involved. But then we should also be able to motivate or to state what we do correctly so as to be able to implant slings. Microplastic, also in slings and meshes in the body, I believe is a problem. I don't know to what extent. I think at this stage nobody knows. But the magnitude of implant surgery is probably negligible in the view of, or in comparison to worldwide pollution and the microplastic that we ingest and inhale and eat every day. Mesh infection occurs when the operation has been performed in a sloppy way. And we know that chronic low-keyed infection that doesn't cause clinical obvious signs may cause chronic pains, especially in female. Mesh degradation is a problem we don't know. what the long-term effects really are. And meshes or slings should not be implanted onto areas where there's movement, because if a sling is implanted into an area where there's relative movement of tissues above and below the sling, that causes chronic and excessive scar tissue and also erosion. So if we use meshes, also in abdominal surgery, we should use it in such a way that the relative movement after implantation is minimal. Then it's the best way to be encapsulated or to be ingrown into the tissues without too many long-term problems. So minimizing the problems of male sling surgery is the correct indication. We should use a sterile surgical technique, meshes and slings only in areas of limited mobility. And there should be no direct contact to crucial structures like vessels or nerves. The measures we can take that slings should be implanted by experts in centers of excellence. They should all have certified training, and all implants should be registered and be made available to clinicians by open registries. Informed consent is logical, and it is better to do this consent long before the surgery, so at time of in the outpatient clinic, so that the patient has got enough time to think and discuss, maybe get a second opinion before the implant is done. And I believe that doctors in this area should get better legal support. So to mesh or not to mesh? If we use biologicals, then we need to improve the tensile strength of biologicals. Is it maybe possible to grow facial slings or fascia from stem cells? That may be one possibility. What does the ideal sling look like? Macroporous, monofilament, lightweight, as small as possible, no knots, and maybe embedded with some kind of material to prevent long-term infection. Is there a problem in mesh? Is there a problem with mesh in men? Yes. We've got poor studies. To my mind, there's inadequate input from university training centers and from academia onto the long-term effects of foreign material and meshes and slings in bodies. And in Europe, there's an absence of accessible implant registries, and we have got a big problem with litigation. On the other hand, if we want to help a patient in need of repair for incontinence with a quality product, CE and FDA approved, by a trained surgeon maintaining good clinical practice in centers of excellence, including entering these meshes and slings into a register, I see no problem in using male slings in men. And we as doctors have to learn to step aside from the awkward position being scolded upon because using meshes, we should not be emotionally challenged that we become emotional about it and can't think anymore. We should just step aside and think, what do we do right? And why is it still necessary to, for the correct indication, still use a sling? So even in this day of litigation, I think it is possible and recommendable to use a sling for the proper indication, although in the long term it might not be the ideal and final answer. Thanks very much.
Thank you very much, Peter. What's your feeling, I mean, in your vast experience, the incidence of chronic pain and urethral erosion for male slings, the problems we've seen in the women?
Yes, I can speak for the advanced sling, the male sling, which causes or which works by a retroluminal support. I've done more than 500 of these slings, and I haven't seen any erosion in patients performed for the right indication. I have experienced 2 erosions in patients that had irradiation before, and one of those, the urethra was injured during the operation. And then it is interesting also For other male slings, the incidence of chronic pain is much less than in females. And in females, it has been shown that chronic pain has been associated to chronic infection. So maybe there's a role. Where I've seen pain is if a trans-operator approach was used and going through the operator fossa too lateral. Then you injure the ductors, you cause a hematoma, and you might cause more fibrosis. There I've seen pain, but if it's close to the inferior pubic ramus, I've seen a very low number of pain, less than 1%.
Yeah, I think that's generally the UK experience as well from a recent meeting we had. So would you advise against slings in the post-radiotherapy group?
In general, yes. There's a small group of patients, the elderly man that has had irradiation, but on perineal ultrasound, you see a well-vascularized bulb. He doesn't want the sphincter. There may be an indication for this patient, but then you have to tell him, I probably can't make you continent again, but I can definitely improve your situation.
Any more questions? What about indications in terms of, have you got an upper limit of pad weights where you would not agree to a sling? Because a lot of these men want a sling in preference to an AUS.
In our practice, in Innsbruck, I use either for the very incontinent patient the AUS, and then for the mild, of course, the advanced sling, and then there's a middle group of patients. The main criterion for using a retroluminal support sling is being dry at night. Now, if this same man goes to play a game of tennis and loses the whole contents of his bladder during that game of tennis, especially in the afternoon, he might be classified on a 24-hour pad test as severely incontinent, but might still benefit from an advanced sling. So I don't place an absolute limit on pad weight if the patient is dry at night.
Brilliant. So that's indicating residual sphincter function,
yes.
Basically. Yeah. Great. If that's all the questions, then we'll move on.
Okay.
Thanks very much.
Thank you very much.